We are now moving more deeply into this unit called professional contexts or professional relationships. Last week, we looked at two of the most fundamental and significant obligations that healthcare professionals have. The obligation to tell the truth, to involve their patients or clients in the decision-making process by meeting the requirements of informed consent, and respecting patient confidentiality and privacy. This week, we're looking at relationships among healthcare professionals, with a particular focus on the problematic relationship between physicians, who are often, but not always, male, and nurses, who are often, though not always, female. Let's begin to think about this context of understanding healthcare professional obligations. Let me begin with two background considerations, both involving claims. The first one, a descriptive claim. The fact is, you will practice your professional craft in a team or a cooperative environment where you will be interacting with others who share your professional training and status, some from different healthcare professions, and with physicians, who are typically recognized as having the greatest authority in the healthcare practice context. Now, let me add to that descriptive claim a moral one. Other professionals have a legitimate expectation of you with respect to your conduct in those cooperative contexts. Put differently, you relate not only to your patients, but also in the care of those patients, you relate to other healthcare professionals. And if we look at your professional codes, we will notice this, that they refer to your obligations to other professionals as well. Now, they tend not to distinguish between those who share your profession and other healthcare professions, and they tend to be silent with respect to this matter of the unique authority of physicians. Look, for example, at the American Nurses Association Code. The principle of respect for persons extends to all individuals. The nurse maintains compassionate and caring relationships with colleagues, your fellow healthcare professionals, and others, with a commitment to the fair treatment of individuals, to integrity-preserving compromise, and to resolving conflicts. Or look at the PA code. Pharmacist code, excuse me. When appropriate, a pharmacist asks for the consultation of colleagues or other health professionals or refers the patient. A pharmacist acknowledges that colleagues and other health professionals may differ in their beliefs and values, they apply to the care of patients. Or this from the AMA, a physician shall respect the rights of patients, colleagues, and other healthcare professionals. Now, I think it's appropriate to point out, and you were probably thinking, these are very broad, very general claims, but surely they indicate a recognition in the codes that your relationships with fellow professionals are very important. Now, in this presentation, we're going to focus on a particularly interesting and problematic relationship, the relationship among doctors and nurses. Now, many of you are not preparing to be nurses, and there are many other healthcare professionals who work in relation to physicians. So I think some of the problems and some of the thinking related to the nurse-physician relationship is relevant to relationships between physicians and other healthcare professions. Let's begin by looking at this incident described in a blog. It is a description of some kind of a supervisory nurse talking about a problem that one of her nurses came to her with. Here's what she wrote. A nurse, noted for her competence and kindness, was approached by a well-respected physician wondering why the blood pressure medications of a certain patient were being held over the past few days, and he was not notified. This nurse, being very diplomatic, offered a response to the physician. I'm not sure. I didn't even know that happened. Let me look into it for you and get back to you. Unrelenting, the physician pressed farther. There's no need for you to look into it further. I've been sitting here for 20 minutes looking at the blood pressures and medications given, and it makes no sense. Getting louder with each word. Knowing she could offer nothing useful in this conversation with it escalating, she simply walked away saying, I don't know, I've literally taken care of this patient for 4 hours. The nurse pulled me aside to talk it out. She was worried she had done something wrong. At this point, we were both thinking, honestly, we do not get paid enough to deal with this type of interaction. And now, this comment. Physicians come with a full picture of the patient that they've known over months to years. Nurses come in and get a snapshot of the patient that the previous nurse discloses. Over the first 4 hours of our shift, while we are running around attempting to maintain sanity, we may not get a chance to look back over specific details for individual patients. I think bigger questions come to light in the midst of these types of interaction. Where is the mutual respect among colleagues here? Where's the teamwork? If we continue to treat each other, and this goes both ways, not just physician to nurse, in this way, it undoubtedly will be to the detriment of patient care. I understand this occurs both ways, and my intention here is not to bash physicians. I simply want to shed light on a problem that needs addressing. Now, from my experience in listening to nurses, the interaction described here is not at all uncommon. It's a realistic portrayal of what happens day to day on hospital floors. Let's think about this case that is one about which you might write. It involves conflict between a nurse and the physician under whom she works. Michael G., who is dying of leukemia, is in a hospital where he is receiving chemotherapy. A registered nurse involved in his care, Nurse L., learns that he has never received information about alternative natural therapies. She gives Michael G. the information and discusses the advantages and disadvantages of the various alternatives. After extensive reflection and consultation with his family, Michael G. decides to leave the hospital and to make arrangements to try one of the alternative therapies. He informs the attending oncologist of his decision. When the oncologist learns about the source of Michael G.'s information, he confronts Nurse L., suggesting that her comment has been unprofessional and threatens to seek the revocation of her nursing license. She argues that the patient had a right to know about the alternatives, and without that knowledge, his informed consent to chemotherapy was invalid. An interesting case, isn't it? Involving issues both related to informed consent and to the nurse-physician relationship. Who was right in this scenario? The nurse or the physician? Was the nurse's behavior justified? So what are the legitimate expectations of doctors with respect to nurses? What is the nature and basis of the physician's authority? Why and to what extent should nurses and other healthcare professionals be expected to obey doctors? And is the doctor's authority and nursing obedience consistent with the model or ideal of nurses and other healthcare professionals as autonomous professionals with authority and responsibility independent of that of the physician? Let's think first about the nature of authority and the obligations others have to respect that authority. What does it mean to have authority? Well, I think obviously it means that one's ultimate or final judgment is unchallenged. And I say one's ultimate or final judgment. Having authority does not mean that those under you can question you or challenge you or ask you to think more deeply. But once the person in authority has decided, that judgment is unchallenged. And that means one's commands or orders are followed. Those having the obligation to respect authority are obligated not to challenge the ultimate or final judgment of those who have authority, and they are obligated then to obey the commands of those in authority. Now, on what basis and why might physicians be said to have authority, and nurses and others an obligation to respect that authority? Lisa Newton addresses that issue in her essay, which you have been assigned, called In Defense of the Traditional Nurse. She argues that the basis of the physician's authority is the physician's unique medical expertise. She writes, among the prominent features of the practice of medicine are the following. It depends upon esoteric knowledge, which takes time to acquire, and which is rapidly advancing. And because each patient's illness is unique, it is uncertain. Thus, when a serious medical condition arises without warning, only physicians will know how to deal with it. I should explain, the word esoteric means secret or hard to acquire or not broadly known. The physician's knowledge is special and unique. Now, Newton adds to her argument two other considerations, one having to do with the nature of hospitals as bureaucratic institutions, and the other related to the unpredictable and urgent context in which medical conditions often arise. Here's what she writes. To take the hospital bureaucracy first, its very nature demands that workers perform the tasks assigned to them, report properly to the proper superior, avoid initiative, and adhere to set procedures. These requirements are common to all bureaucracies, but dramatically increase in urgency when the tasks are supposed to be protective of life itself, and where the subject matter is inherently unpredictable and emergency-prone. Since there is no time to re-examine the usefulness of a procedure in a particular case, and since the stakes are too high to permit a gamble, the institution's effectiveness, not to mention its legal position, may depend on unquestioning adherence to procedure. End of quote. So we have explained something of the nature and basis of the physician's authority. And clearly in Newton, we have an argument to suggest that nurse obedience to the physician should be complete and near total, we might say. But the question this raises is whether this account of the doctor's authority and nursing obedience is consistent with an emerging idea of the nursing profession and other healthcare professions as autonomous professionals. Let's look at what that means. The nurse as an autonomous professional is grounded in the idea, in some new ideas of nursing that have emerged over the last 40 and 50 years. It reflects the nurse's desire, of course, for increased professional status and salaries and social respect, but it's justified largely in terms of the more expansive knowledge and education that nurses have and the more significant contribution they make in the healthcare team in the modern world. This idea points to the nurse's independent authority and practice based on her own esoteric knowledge or unique knowledge and skill, and it suggests an interdependent relationship with other healthcare professionals on some greater equality than in the past, and that greater equality and interdependence with other professionals generally is thought to include physicians. Now, it's obvious that Lisa Newton, in her defense of the traditional nurse, critiques the idea of the nurse as an autonomous professional, believing that it wrongly challenges and undermines physician authority. There's some things I want you to notice about Newton's argument or her reasoning in defense of the traditional nurse. Notice its focus on the patient's needs and welfare. This is important because we're going to look at Cuse's response to Newton and her alternative Newton. She too is focused on the patient's needs and welfare. And that suggests the ultimate resolution to this issue, you might say, everyone agrees, has to do with what's best for patients. Now, of course, Newton's concern is that given the medical and hospital context, what patients need above all else, she says, is a physician whose authority is unchallenged. If the two contexts of medicine and the hospital are superimposed, three common points can be seen, she writes. Both are devoted to saving life and health. The atmosphere in which that purpose is carried out is inevitably tense and urgent. And if the purpose, promoting patient welfare, is to be accomplished in that atmosphere, all participating activities and agents must be completely subordinated to the medical judgment of the physicians. Those other than physicians involved in medical procedures in a hospital context have no right to assert their own needs, judgments, or personalities into the situation. The last thing we need at this point is another autonomous professional on the job, whether a nurse or anyone else. So what does she believe that patients need from a nurse? She says what they need is a surrogate mother or a replacement for their own mother, someone who provides specialized care when the physician isn't around, someone who gives assistance with simple daily tasks like going to the bathroom or eating, and they need emotional support. Now, in her argument for the nurse as a surrogate mother, you should notice her appeal to the origin of the word nurse, right? The word nurse comes from the mother's nursing of an infant. Newton makes another interesting point that distinguishes care from cure. She suggests that hospitals can become what she calls moral monstrosities when it is focused so exclusively on curing, on addressing the person's medical needs, that it forgets to care for the person, for the patient as a whole person. Nurses, in being surrogate mothers to patients, fulfill that role. They do that by providing specialized care, assistance with daily tasks, and emotional support, as we've talked about. She says for the nurse to fill that role, they must be a mother without power. You should notice the quotation on page 36 where she talks about mothers as powerless, and the very fact that they lack power enables them to be the kind of emotional support that children and patients need. Well, those are some interesting points that Newton makes. Finally, notice that she believes that if nurses accept this non-autonomous role, that does not mean they have lost their autonomy as a person, independent of themselves as a nurse. She seems to be appealing to nurses as persons to voluntarily, autonomously accept this surrogate mother role and the loss of autonomy implicit in it. Helga Cusa's essay, Advocacy or Servience for the Sake of Patients, is a kind of response to Lisa Newton's argument. I do want you to notice that in the title of her article that she sees advocacy as the alternative to subservience as the basic metaphor for what nurses do. And I also want you to notice in her title, For the Sake of Patients. Cusa's complaint and Cusa's argument with reference to Newton has to do with which idea of nursing is best for patients. Now, let's look particularly at her understanding of the limits of physician authority. I say limits because Cusa, as no one else, I think, denies that physicians have a certain kind of authority. And she specifically agrees that doctors have special medical expertise, particularly expertise that justifies their authority in emergency situations. Look at what she says. There is no doubt that doctors have special medical expertise that is relevant to the achievement of various therapeutic goals. As a general rule, but only as a general rule, there could be exceptions to this rule, doctors would thus be better equipped than nurses to respond to a range of medical emergencies. In emergency situations, then, where urgent action is required, it is likely that the best outcome for patients will be achieved if doctors are in charge. End of quote. However, Cusa challenges Newton's idea that the hospital is a context in which things are always unpredictable and urgent. This, the authority of physicians in emergency situations, does not entail that the doctor should have overall authority as far as patient's treatment is concerned. The authority to decide on an operation or on the desirability of implementing resuscitation procedures might, for example, rest with the patient or her relatives, and the nurse could conceivably be in charge of the overall treatment plan of the patient. Unquote. Again, the point here has to do with the absence of necessarily an emergency context, a context of unpredictability and urgency. Moreover, Cusa argues, doctors are fallible, and nurses have their own professional intelligence to draw upon, particularly in situations where a doctor's knowledge may be lacking or wrongly applied. It does not follow, she writes, that nurses must, even during emergency procedures, blindly follow a doctor's orders. Doctors, like the rest of us, are fallible human beings and sometimes make mistakes. Given then that doctors will occasionally make mistakes and that nurses frequently have professional knowledge to detect them, it will be best if nurses do not understand their duty to follow doctors' orders as absolute and exceptionless one. The nurse must bring her own professional integrity into play. You should notice that in making this point, Cusa refers to the fact that nursing knowledge has expanded dramatically over the decades, and as a result, a redefinition of the scope of nursing practice, an expanding definition of the scope of nursing practice has rightly developed. This justifies her sense that an autonomous nurse, a nurse who is an advocate for patients, is preferable to a subservient nurse who plays the role of a surrogate mother, as Newton would suggest she should. Cusa explicitly critiques the idea of nurses as surrogate mothers, taking on the idea that Newton has presented that patients experience humiliation and therefore have strong emotional needs that only a nurse can meet. She suggests that is hardly a valid generalization about all patients in hospitals, as this quotation suggests. Also, even those with strong emotional needs, she says, don't necessarily need a powerless surrogate mother. She says, then there are those patients who are seriously ill and whose self-concept may indeed be threatened by the medical treatment they are receiving or by their incapacitated state. Many of these patients will undoubtedly benefit from the presence of a caring and sympathetic nurse who will listen to them with warmth and understanding. But would they want the subservient nurse Newton holds in store for them? I doubt it very much. By refusing to engage patients in meaningful ways, she would be signaling to them that she does not take their concerns seriously, which isn't at all what they need. Interestingly, I didn't point this out earlier, but a part of Newton's argument for this powerless surrogate mother nurse is that if the nurse actually had power to change the treatment plan, to change the realities that surround the patient, patients would be reluctant to complain to nurses. They need to be able to complain without the fear that their complaints will actually be listened to or heard, which Cusa finds a very strange argument. Let's return now here at the end to that case we've referred to, the nurse and informed consent. A situation in which a nurse went around or beyond the physician under which she worked to inform a patient about alternative therapies that the doctor had not informed him of. On the one hand, the nurse seems to be fulfilling the requirements of informed consent in relation to the patient, but one might argue that she is threatening the proper authority of the physician in the particular way that she did it. You can write on this case, and the question you are to answer is, was her behavior justified? Let's look briefly here at the end at how the dilemma in this case might be analyzed. We might believe that what the nurse did was justified because it met her obligations of fidelity to the patient as defined by informed consent requirements. Informed consent, of course, justified in terms of both beneficence and autonomy. Beneficence, if indeed he will be better off with the alternative medicine, and autonomy in the sense that, of course, he must be informed to exercise his autonomy. On the other hand, we might say that she violated her obligations of fidelity to the physician, that she has failed to live up to his legitimate expectation that she respect his authority. We might also say she has actually undermined patient welfare by her behavior if, in fact, the alternative medicine is unproven. Much here hinges upon whether or not informed consent requirements require information about alternative medicines, and that on whether, in fact, alternative medicines actually benefit patients. So this, you can see, is an interesting case involving several issues: informed consent, legitimate expectations of physicians in relation to nurses, and finally, of course, issues related to alternative medicine. This concludes our discussion of interactions among doctors and nurses. Hopefully it has been for you a useful introduction to at least some of the issues related to those interactions.